Good morning and welcome to the second installment of our webinar series on the Mental Health Parity and Addiction Equity Act, or MHPAEA. It's a mouthful. Before we get started today, I want to take a moment to consider a hypothetical scenario with two employees. Bill and Sarah are both dedicated employees working at the same company. Sarah needs to get a knee replacement while Bill silently struggles with mental health issues. Despite their equal commitment to their work, the treatment they receive is vastly different. In the first scenario, Sarah is very open about her knee replacement and is met with understanding from her coworkers, and accommodations are made to accommodate her through her medical treatment, and her coworkers are wishing her well. Her health plan provides comprehensive coverage for her treatments, and she feels like she can find the specialist she needs. On the other hand, Bill's mental health struggles are not as visible. And because of his company's culture of work hard, push through, he doesn't feel like he's encouraged to come to the team and let them know that he's struggling. He's also struggling to find in-network providers, but again, he doesn't feel like he can come to anyone to get help with his treatments. When a company isn't aware of how to implement this act, the situation can change dramatically. Bill and Sarah could still face these same individual challenges, but if implemented correctly, those colleagues are more educated, there's a more open culture, and we make sure that everyone is covered at the same level. If we think about this for a moment, we really hope that your company's situation is more like the latter, because you as an employer or benefit plan partner play a pivotal role in mental health and the well-being of your workforce. So we hope that you're encouraging a culture of care. Hello, everyone. I'm Jennifer Austin, Senior Director of Strategic Marketing and Employer Engagement here at the Alliance. I will be moderating today's session. The Mental Health Parity, Addiction and Equity Act is a federal law requiring health insurance plans to provide equal coverage for both mental health and substance abuse services. Our goal is to help you adopt a proactive mindset so you know how those proposed regulations may impact your business in 2025 and what you can be doing now to minimize risk for your organization. As I mentioned, today is part 2. In session 1, we really covered those fundamentals. You can view that session on the Alliance events page or on our YouTube channel, and we'll also put a link to it within the chat. Note you will be muted during the presentation. If you have questions or need technical support, please type that into the chat box on your screen. We have several handouts available for today's session, including a copy of the slides where you can take notes, and a document that we shared in session 1 to assist you in promoting employee well-being within your organization. For broker consultants needing CE credits, download and sign the form, also found in the handout section. For those looking for SHRM or HCRI, you can email events@the-alliance.org. And a recording of today's event will be made available on our website, and we'll email a link out to attendees when it's available. Finally, I want to take just a moment to thank our sponsors, Delta Dental and National Cooperative RX. We truly appreciate your support. It enables us to continue bringing valuable programs like this to our employers and benefit partners. So today, I'd like to welcome John Barlament, a friend of the Alliance, to help us learn a little bit more about the proposed regulations impacting the Mental Health Parity and Addiction Equity Act. John is a benefits attorney who works with employers and health plans on various legal issues with a focus on health and welfare. He has vast experience and frequently presents on these topics, and is a national leader and has been interviewed by and quoted in leading publications like the Wall Street Journal. Thanks so much for being here today, John.
Thanks, Jennifer, and thanks everyone else for being here too. It's good to be back, and I think part 1 went pretty well in terms of all the comments and everything. And let me just make sure that I'm going to share my screen. Jennifer, do you see it? I just want to double check. See the slides?
It looks great.
Hey, we're rolling. All right, sounds good. So All right, so today, again, we're kind of doing a MHPAEA update part 2. In the first session from a couple months ago, you may remember that in part 1, we discussed some more basic information in terms of which plans are subject to MHPAEA. We talked about the old rules, the quantitative treatment limitation, QTL rules, which are often forgotten, unfortunately. So, again, if you haven't ever done a QTL test, and I would guess that the majority of my clients even probably haven't done a QTL test, it's probably a good idea to do that kind of test. Just make sure that there's no lingering issues out there. We also went through the 2021 FAQs from the DOL, IRS, and CMS. Those are the three main enforcers here. We talked about the different action steps that employers should take to comply with those FAQs. Basically, what you have to have is a written comparative analysis comparing how your non-quantitative treatment limitations and QTLs apply to medical surgical benefits versus mental health or substance use disorder benefits. So there's two sides of the house. That's true under the 2021 FAQs. That's true under the 2023 guidance that we're going to be talking about here today. So again, NQTLs as they apply to each side of the house. By NQTLs, again, same definitions here for 2023 that apply in the 2021 guidance. NQTLs are any kind of softer limitation, like a prior authorization requirement, a medical necessity requirement, an experimental or investigational exclusion provision. Those sort of NQTLs are what's at issue both in the 2021 guidance and in 2023. So where do we kind of leave off here? The industry had requested from the DOL, IRS, and CMS that we get more guidance because it was unclear how we were supposed to apply these Consolidated Appropriation Act, CAA changes that came into effect in December of 2020. So we pushed as an industry, and the DOL, IRS, CMS delivered, for better or for worse, with some additional guidance in late July 2023, early August 2023. Basically some new proposed regulations, a technical release, and then a report to Congress. They're all interesting. They're all kind of important. Probably the most important is the proposed regulations. We will spend a little bit of time on the other items here too, though. In terms of the proposed regulations, a couple things to note up front. First of all, these regulations are only proposed, which means that they could be changed. There's a good chance that they will be tweaked. If you look at some of the comments, which were due in about the mid-October 2023, if you look at some of the comments, some of the big industry groups said these regulations are unworkable, that they need to be completely thrown out. The regulators, need to completely start over. I'm not so sure that the regulators are receptive to that type of burn it all down type of approach. And so I could see that they clearly put a lot of thought into these regulations. And I would suspect that they're going to be maybe a little bit defensive and not want to completely throw everything out. So I would think that they would be unlikely to jettison everything. So I would think that the stuff that we're talking about here today, I think it probably will survive in some form, maybe with some modifications. But that's really just a guess. I'm not quite sure where this will go. The regulators are hoping to have final regulations be effective for plan year starting January 1, 2025. And in order for them to do that, I think they would have to provide a sufficient amount of time for plans to comply before January 1, 2025. That to me suggests, again, kind of reading the tea leaves, gazing into the crystal ball, that we would probably expect some final regulations maybe here in the first quarter of 2024. If they arrive too much later, January 1, 2025 is not a likely effective date. I think it'll slip to January 1, 2026. And at that point, the regulators, I think, will be very frustrated that it's got delayed by a whole nother year. So maybe July 1, 2025 would be another possible date. But anyways, there's going to be pressure on them to probably give us some kind of yay or nay here, yet this first quarter, maybe into April or May 2024. So we'll see. In terms of what the proposed regulations provide, let's kind of go through them here. So the preamble is always interesting to read. It reveals that the 0% success rate of the industry that we talked about in the last session really has not improved much in the 18 months since that first report to Congress. Regulators found that nearly all plans or health insurance issuers audited for MHPAEA compliance could not demonstrate compliance, especially evident with respect to the design and application of NQTLs. Plans and issuers continue to fall short, et cetera, et cetera. So really kind of roughing up the industry. Again, the industry, employers, TPAs, PBMs would push back on that narrative and say, well, if we're all failing, maybe it's not that the students are all, incompetent. Maybe it's the teacher who's not giving us enough guidance on how to do this. So that would be kind of the counter narrative there. In terms of the main changes here in these proposed regulations, first of all, plans would be required to collect and evaluate outcomes data and take action to address material differences in access to mental health substance use disorder compared to medical surgical benefits. To have any NQTL subject to a few exceptions, for example, for generally recognized independent professional, medical, or clinical standards, or for fraud, waste, and abuse, we're going to need data. So again, this is kind of an important point. This is a very important bullet point here. In general, if we don't have data to back up an NQTL to sort of demonstrate from a numerical perspective that the NQTL is not disproportionately impacting mental health or substance use disorder benefits, without that data, you can't have an NQTL unless you can point to independent professional, medical, or clinical standards where they say, yes, this is kind of the standard of care. This is how this should be treated. Or independent fraud, waste, or abuse standards. So it is an important change. It really builds on the 2021 data and analysis. So in other words, you still have to do the 2021, but this is adding a new layer of data on top of the 2021. So we have a little tower here that they continue to kind of build out, if you will. Number two, the new proposed regulations would codify the requirement to conduct meaningful comparative analyses to measure the impact of NQTLs, includes evaluating standards related to network composition, out-of-network reimbursement rates, and prior authorization NQTLs. What does this mean? It means that basically the regulators are very interested, as you'll see later on, we'll have some more slides on this, very interested in trying to have you show that your network composition is sufficient, that there's enough mental health providers in the network compared to medical surgical providers in the network. So they really want to have you prove that through data analysis. If you're an employer, how are you going to prove that? You're not going to prove it. What you're going to do is you're going to go talk to your TPAs and PBMs and get them to, demonstrate this through data, because they're the ones who are going to have the data as a practical matter. And so again, that'll be kind of a practical solution that we see happening here. Meaningful benefits have to be provided in certain situations. We'll talk about that a little bit more. The proposed regulations also provide examples in general, including more examples of what limits are in QTLs. We're up to dozens of known NQTLs. In theory, there's an unlimited number of NQTLs, but we're starting to get some more guidance on what NQTLs even are. There's a sunset provision for self-funded non-federal governmental plans where they used to be able to opt out of this entirely. That is going away here, or kind of went away. Plans cannot impose a financial requirement of treatment limitation applicable only with respect to mental health or substance use disorder benefits and not to any medical surgical benefits. That kind of makes sense. That's kind of a direct picking on mental health benefits. And then the last one, kind of general. In general, the focus is not just on the process, which is what was true under the 2021, but on the results and the data. So 2021 FAQs, are you following the same kind of process? We still have to keep doing that, but now, in addition to showing the same process, now we still have to demonstrate compliance through data and results, if you will. Other comments in the proposed regulations, again, not to beat this drum too much, but the DOL was very disappointed in the industry. Many initial responders seemed unprepared to submit their comparative analyses upon request. Some plans did not complete or start a comparative analysis until after one was requested. And the lesson here, I think, for employers is the agencies really expect plan sponsors to work on it now, not when a request comes in. In other words, they anticipate, if you will mentally picture this, they anticipate that you will have your NQTL analysis sitting on the shelf behind you in your office. And when somebody from the DOL calls up and says, "Hey, can you send us your NQTL analysis?" they picture you reaching behind your desk and grabbing it and sending it off to them. That's what they're expecting to be in place right now. Now that's not necessarily realistic. I mean, again, we struggle with some of the guidance that's out there, and so this is usually a work in process for most employers. So there's a definite disconnect between what I see in the real world and what the DOL is sort of expecting people to do. But nevertheless, keep in mind that's what the DOL thinks you will all have handy right now. And they went so far as to clarify that they believe that this is a document which is covered under ERISA Section 104. Why is that important? ERISA Section 104 is the provision which says that you have to produce certain documents upon request, like a summary plan description, an SPD. In other words, they're viewing this as kind of a core fundamental document, just like an SPD is a core fundamental document. And you have to provide those kind of core fundamental documents within 30 days of the request. So again, specific time frame there, they do expect this to sort of be ready to go. So what are we going to end up with? What is this comparative analysis going to look like? If you ask your current TPA or PBM for their comparative analysis, you'll see that most TPAs and PBMs, first of all, have done it. Some have not. Some are choosing to not do anything here. But for the ones that have done it, most of them do it in kind of a chart format. Where they say, okay, let's take all these different sort of classifications like inpatient and network, and we're going to do an NQTL analysis of prior authorization for inpatient in-network benefits. And that chart may be anywhere from 3 to 10 to 15 pages long. And then they'll do the same kind of analysis for inpatient out of network. And they kind of go through it step by step by step by step. And you'll end up with anywhere from, for TPAs, anywhere from 10 to 30 charts or so. It can really vary depending on how many NQTLs they have. PBMs tend to only have maybe 3 to 6 NQTLs, so their charts tend to be a lot shorter. But again, that's where what you're ultimately going to end up with is what I've been telling clients is, work with your TPA, work with your PBM, get their starting point chart, kick the tires on it, try to find weaknesses, pretend that you're a DOL agent, what additional questions would the DOL be asking, and then modify their chart, update it specific for you. Is there something that you request that they do which is unique? That's kind of the goal. That's what you're sort of looking to do is usually just try to update their chart and then kind of use that as your comparative analysis. That's kind of where we're steering the ship. That's where you're ultimately going, I think, here for most clients. All right, so data. So again, putting together these charts, a lot of work. When you look at some of these charts, they are very long. I think UHC's is like 180 pages long. Cigna's, Aetna's, they're all very, very long, well over 100 pages. So a lot of work went into them. But the new 2023 guidance says that's a great start, but now you have to take it to the next step. You need data to support every single thing that's in those charts. So language in the plan and SPD is good. Language in the template the NQTL documents is good, but those are not going to be sufficient. You're going to need more. And then the question becomes, will your vendors, will your TPAs, will your PBMs provide that additional data? And my guess is that you, as the employer industry, are going to put a lot of pressure on the PBMs and TPAs and others to provide that data to help out here. Note that the TPAs and PBMs don't have to do it from a legal perspective. They could just say, sorry, it's your issue as a plan sponsor, but I think there will be enough pressure from the employers where that type of approach is likely, where they will assist. Maybe they'll charge for it. I wouldn't be surprised at all if they charge for it, especially if this is as burdensome as it could potentially be. So again, that's where I kind of foresee things going here in the next year to 2 years, is this sort of coordination between the employers pushing maybe gently, maybe strongly on the TPAs and PBMs to help out here. All right, so what else do they say here? Again, without the relevant data and this new analysis being done, plans and issuers would not be permitted to impose the NQTL. So again, if you don't have the data kind of backing it up, that means that your plan document has to change. You have to modify your SPD. You can't impose like a experimental or investigational limitation on a particular benefit because you can't justify it. You can't impose a prior authorization requirement because you can't justify it from a data perspective. So it's a significant issue. It could require you to, in the middle of the plan year, if you don't have the data, pull the plug on some of these NQTLs, things which are very important in terms of controlling costs. So employers don't want that. You don't want the plug to be inadvertently pulled and for you to lose an NQTL that you currently have used, now and you've used probably for decades. So again, it's an important thing to get right here under these proposed regulations. The to-do here, again, the agencies believe that the issuers and TPAs are the ones that are going to have this data. And so the to-do, if you will, is, talk to your vendors about this, strategize it, discuss the approach here is high level where I think this is going to go. All right, so when we talk about data, what are we talking about here? What do we mean? There's a brand new 3-step process to prove that this data-based NQTL approach, that your NQTLs are sufficiently justified. So again, 3 steps. The first one is what we call the no more restrictive requirement, where you are going to have to prove that the NQTL is no more restrictive as applied to mental health or substance use disorder benefits than to medical surgical benefits. And that first test, as you'll see, has subparts, and we're going to go through each of those. Number 2, the plan is going to have to satisfy requirements related to the design and application of the NQTL, what we call the design and application requirements. Number 3, the plan must collect, evaluate, and consider the impact of relevant data on access to mental health benefits relative to access to medical surgical benefits. If there's any material differences, plan must take reasonable action as necessary to address the material differences. One example of this that, again, we're going to go through each of these 3 in much more detail, but one example of this to kind of give you a heads up would be, let's suppose that you determine that you have an insufficient number of mental health professionals in your network. You just haven't drawn in enough mental health professionals. One of the suggestions from the DOL is that you should pay more for those mental health professionals, that you need to open up the purse strings here and start paying these providers more to draw them into your network. Paying them more to draw them into the network is going to cost you more money, right? There's a cost to that. So again, that's an important issue. Now note that they're not necessarily saying you have to do it. It's possible that you have a sufficient number of providers, but that is one of the things that they're suggesting. And all 3 of these must be met in general to impose an NQTL. All right, so let's go through them one by one. The first test, the no more restrictive requirement, is actually broken down into 4 subparts. So you have to satisfy these 4 subparts in order to meet the first test. And again, there's 3 tests. So this is kind of complicated because we're going into 4 subparts of the first test of a 3-part test. First, determine the portion of the plan payments for medical surgical benefits expected to be subject to the NQTL for the plan year. So again, data. What portion of the plan payments for medical surgical are going to be subject to this NQTL? How are you going to get this data? Most employers are not going to have this data you're going to have to go to your TPA, you're going to have to go to your PBM, other vendors out there and try and gather that data. Will they give it to you? Will they view this as proprietary? Will they view it as confidential? Are they going to try and lock it down? Are they going to charge you for it? Those are kind of the open issues that we'll see where things go. But initially, you're going to have that conversation with them and verify if they'll do this for you and if they'll do it for you every single year. So this is potentially something that needs to be done every single year. We've gotten questions from clients about that. Do we really have to do this kind of analysis every year? What I've been telling them under the 2021 guidance is that I don't think it necessarily has to be done every year, but if you change vendors, if you make a major plan redesign, then you do have to look at it every year. That guidance may change. My thought process may change under this 2023 guidance because now we're dealing with data. Data could vary from year to year. Let's suppose that in 2025, you barely skate by from a data perspective. You're within 1% of perhaps, failing this test. I think, if it's that close, you'd probably want to do the same test in 2026, maybe 2027. So in other words, if you are on the razor's edge of potentially failing, I could see how you may have to do this kind of analysis every single year to be able to prove it. Versus again, in 2021, under the 2021 guidance, if you satisfy it, looks pretty easy. I've been telling clients, no, I don't think you have to do it every year. That advice could flip depending upon what these final regulations say here, likely in 2024. All right, Part B, determine whether the NQTL applies to substantially all medical surgical benefits in the classification. So again, is it applying to substantially all of those medical surgical benefits? How do we figure it out? It's based on the planned payments for medical surgical benefits subject to NQTL as a portion of the dollar amount of all planned payments for medical surgical benefits in the classification expected to be paid under the plan for the plan year. Note that last phrase, expected to be paid under the plan for the plan year. They sort of anticipate that this is a forward-looking requirement. So, in 2026, you would look at it in 2025 and try and figure out what the numbers are going to look like in the future year. So now I think, it's unclear whether you're going to need an actuarial analysis, or I think probably more likely, because they haven't said it yet, probably more likely you'll just say, okay, here's what numbers were in 2025. Let's multiply it by 4% or 5% or whatever medical inflation is. Again, unless you're kind of redesigning your plan and making a significant change. So that's where that stands. The NQTL must apply to at least 2/3 of the medical surgical benefits in order to be allowed at all. So again, we're gonna have to figure this out. Does this NQTL apply to at least 2/3 of those medical surgical benefits? The DWEL has noted a concern that this data may not really be tracked by vendors right now, and they requested comments on whether vendors maintain systems which are capable of making this determination and the potential burdens associated with it. Again, to do for plan sponsors, employers, advisors to employers, discuss this with the vendors. Vendors, figure out what you track, what you don't track. Is there something that you should be tracking that you're not tracking right now? And then I think the vendors and the employers should be talking and saying, hey, do we want to wait until final regulations are issued, or should we be doing something more now? I'm particularly worried about some of the data collection issues where the regulators seem to assume that this regulation may flip on say January 1, 2025, and that you're going to have to use 2024 data to justify 2025 NQTLs. If we're supposed to be using 2024 data, that means that we should have been tracking this since January 1, 2024. And so if your vendors haven't been doing it for the past 18 days, arguably there is a level of concern associated with that. So again, employers, I think, have this discussion with the vendors, figure out what their approach is. Does it seem reasonable? If they say, yeah, we're already on top of this, we're gathering it, we're good, or are they saying, what are you talking about? We've never heard of those rules. That would be probably a little more concerning. So So I think at this point, again, having that conversation is a good idea. All right, subpart C here. Again, this is still first test. Subpart C, plans must determine the predominant variation of the NQTL that is applied to substantially all medical surgical benefits. What does predominant mean? It means the most common or most frequent variation of an NQTL within a benefits classification. And we'll have an example here kind of demonstrating this. The last part here of this 4-part test, the NQTL must be applied to mental health or substance use disorder benefits. Can't be applied more restrictively than the predominant NQTL applied to substantial medical surgical benefits in the same classification. And restrictive means that the NQTL imposes terms, conditions, or requirements that limit access to benefits under the terms or plans of coverage. All of that is difficult to follow, right? Because it's all high level, pie in the sky kind of words, a lot of words. But let's go through an example here. So, detailed example, medical necessity determination, very common. Every health plan says we're only going to pay for things which are medically necessary. So a medical necessity determination is used under the plan for all inpatient in-network benefits. So it's an NQTL that's applying to all inpatient in-network benefits, medical, surgical, or mental health. For all benefits in that classification, inpatient in-network, prior authorization is granted for either 1 day, 3 days, or 7 days is kind of the standard prior authorization grants. So how do we analyze it here? For medical surgical benefits, let's assume that the approval for 7 days is the most common number. So that's kind of the predominant number here. But for mental health, let's assume that 1 day is the most common number of days approved as medically necessary. After the time period is over, the plan requires a treatment plan, let's say. These time periods, 7 days versus 1 day, are not the result of independent professional medical or clinical standards or standards used to detect or prevent fraud, waste, or abuse. So these are the two exceptions, which if they applied in this example, we'd be done. We wouldn't have to do anything further. We don't have to crunch any numbers. We can just point to this independent professional medical or clinical standard and say, we're good, thanks. But again, in this example, because we want to show it to you, let's assume that that is not true. So now we have to kind of do that data analysis. And again, let's assume that the way this is applied in general satisfies the 2021 rules. So we haven't been deceptive in terms of how we come up with these tests. We haven't been using corrupt third-party resources, things like that. So again, let's assume we're satisfying 2021. Now let's jump through the 2023 hoops. So first we check if the 2/3 test is met. Do at least 2/3 of the medical surgical benefits in that classification, are they subject to this requirement? And the answer is yes in this example. 100% of the benefits in the classification are subject to that requirement, so we meet the 2/3 test. That's good. That means that we can even potentially apply this NQTL. So then we identify the most common or frequent variation of the NQTL. It's 7 days for medical surgical, so usually it gets pre-approved prior authorization for 7 days for medical surgical, but only 1 day for mental health or substance use disorder. So we have a variation there. Now we check to see if the variation is more stringently applied against mental health. Is it worse for mental health compared to medical surgical? The answer is yes. 1 day is more stringent than 7 days. So we're applying it more stringently on the mental health side of things than the medical surgical side of things. Thus, the predominant NQTL is applied more stringently to mental health benefits compared to medical surgical benefits. Thus, according to the regulations, the plan violates the rules of MHPAEA. What does the plan have to do? Regulations don't say, but presumably the plan must approve mental health, substance use disorder benefits in that classification for 7 days. So they need to bump it up from 1 day to 7 days, or conversely, they could limit medical surgical prior approval to 1 day instead of 7 days. So you can either be nicer towards mental health and give a 7-day prior authorization, or you can be meaner towards medical surgical and limit it to 1 day. And again, think about that. I mean, if you are an employer, this is going to be really digging into a lot of data, and you're going to have to, again, kind of crunch these numbers for all these different NQTLs. Again, talk to the TPAs, talk to the PBMs about this, because this is nitty-gritty stuff. This is kind of thorny stuff. And then also keep in mind, this is only the first test. So this is test 1 of 3, those 4 subparts. Now we have to take the same NQTL and also run it through the design and application requirements on the next slide, and the relevant data evaluation requirements in future slides. And again, we think that you're going to want to document this kind of step-by-step process. So a lot of documentation, a lot of analysis here to be able to apply and use these sort of typical NQTLs. All right, step 2. So again, step 2 of 3 here, we got through the first one. What's the second requirement? Plan cannot impose an NQTL with respect to mental health or substance use disorder in a classification unless the plan, as written and in operation, uses processes, strategies, evidentiary standards, and other factors when designing and applying those NQTLs, which are comparable to and applied no more stringently than the factors with respect to medical surgical benefits. How do we figure that out? Well, this is sort of a repeat of what's in the 2021 FAQs, and the guidance, unfortunately, is very vague. It says that those factors can be applied no more stringently than those used with respect to generally comparable medical surgical benefits. But what are generally comparable benefits? This has been a real thorn in MHPAEA compliance now for years. No one knows. So it's very unclear how you match up a particular mental health benefit with a, quote, comparable medical surgical benefit. Take an example of, somebody is going in to an eating disorder residential facility. They have an eating disorder, a mental health condition. Their doctor says that they need to be, placed to a facility and monitored for like 30 days. What is a comparable medical surgical benefit? How does it compare to something else? Would it be like a skilled nursing facility where somebody was in a major car accident and they need to learn how to walk again, and so they're put into a residential facility on the medical surgical side? Maybe that maybe is the best way to match it up, but we don't know that for sure. The agencies have never given us examples like that to say, okay, here is how you figure out what's a comparable benefit. So this remains very legally ambiguous. The regulators are continuing to fail to fix this issue, and it's a problem, I think. So I'm hopeful that when the final regs come out, that maybe they give us even one example of how to do this, because right now, for years, we've had 0 examples. So this is a real problem under the regs, I think, still. So what else do the regulations say on this number 2? If any factor or evidentiary standard relies upon information, evidence, sources, or standards which discriminate against mental health benefits, then you cannot use those sources or factors. How do we figure out if something is discriminatory? Well, if it's biased or not objective in a manner that results in less favorable treatment of mental health benefits, or if the difference is without legitimate justification, or if the information is otherwise not objective, or if it's just old, the regulators don't want you using it. Why are they doing this? Well, I think why they're throwing this one out there is because some providers have been aggressive in what I call cherry picking guidance. So they'll look to 5 different publications, and then they will go through it, and they'll take one standard from one publication, which is kind of more pro-plan, and then they'll get rid of that publication for everything else. And then they go to a different publication, and they kind of cherry pick something which is easy over there. So what the regulators, I think, are trying to crack down on is TPAs or PBMs who are being aggressive in cherry picking standards to end up with something that is biased in favor of plans, basically. So again, that's difficult for you to figure out. Hey, is our vendor sort of cherry picking this guidance? So again, you're gonna have to kind of press them on it, talk to them about their sources, try to get them to put into writing that it's not discriminatory, et cetera. So again, that's a difficult, heavy lift for plan sponsors. but unfortunately, it's what they're throwing out there at us right now. All right, number 3, so relevant data evaluation requirement. So this is the third requirement that must be met to impose an NQTL. Plans must collect and evaluate relevant data in a manner reasonably designed to assess the impact of the NQTLs on access to mental health or substance use disorder benefits. Not quite clear what that means. Some references to state data sources. We may need to, again, kind of prove that we are allowing sufficient access to this. They do have a little bit more guidance on network composition standards, where they're going to expect you, or your vendors, to be able to prove that the utilization rates look good, that the network adequacy metrics look good, like time and distance data. How many mental health professionals are within, a certain circular radius of where the majority of your plan enrollees live. What are the provider reimbursement rates? So these kinds of, hard data to prove that your network looks good, looks efficient, is what they're going to be looking for. They are looking for industry input on how to measure this. So again, in the proposed regulations, they threw out the concept, and then they said, industry, TPAs, insurers, you tell us how you would go up measuring this. So this is one where I don't have a, 3 sub-steps that you have to follow, because they are very clear that they're looking for guidance from the industry. They do say that if you don't have sufficient information here, that you are going to have to take action steps. They don't lay out exactly what those action steps are, but this is the one that I mentioned at the beginning of the presentation. Action plans could include authorizing greater compensation or other inducements to bring more mental health or substance use disorder providers in network. So that means they expect you to maybe pay more to attract more mental health professionals. The question, of course, is what's the cost impact of that? Is this going to cost employers more here to bring in those professionals? Other requirements, meaningful benefits. This one's a little bit vague, but it seems to prevent a plan from providing a range of medical surgical benefits, but only one limited benefit for mental health. I haven't really seen that. I don't really have any clients who do that. Just provide one mental health benefit, but 10,000 medical surgical benefits. But if you're in that category, again, take a look at this, because I think that would impact you. Important new requirement, fiduciary certification. This is really interesting. It says that for plans which are subject to ERISA, a plan fiduciary would be required to certify in writing that they reviewed the analysis and state whether they believe the plan is in compliance with the regulations. So definitely a surprising requirement. Going to put a lot of personal pressure on plan fiduciaries to ensure that everything is legally correct. In other words, there's going to be one person within your organization, presumably within your organization. I don't think a TPA or PBM is going to do this, but it'll be someone within your organization who signs his or her name on the dotted line and says, yes, we think that we're compliant. That's a little bit terrifying because, again, these regulations are vague, historically have been very difficult to apply. It's going to put a lot of pressure on somebody within your organization. And that's the kind of requirement that I think probably would not disappear in the final regs. I would be surprised. So I would think that that would be in the final regulations. Notice of noncompliance, not exactly new, but the regulations provide additional detail on how enrollees must be informed of the plan noncompliance in some situations. So if the DOL finds you to be out of compliance, they're going to give you a 45-day time period to correct it. If you can't correct it, then you have to tell the enrollees within 7 calendar days about your problems. You have to go and confess your sins, for lack of a better term. Why is that important? It's embarrassing, right? It's going to be embarrassing. It's going to be confusing. It's going to put pressure on you. Your plan enrollees are not going to understand, why are you violating the law? What's going on? Will it encourage a lawsuit against you because you've had to confess your problems? So again, you don't want to be in that category. You want to correct it within 45 days if at all possible. But again, that remains out there. All right, moving away from the regulations, what's in the technical release? Technical release discusses various information that plans and plan vendors may need to gather. For example, out-of-network utilization rates, the data from the 2 most recent calendar years. So for example, for plan years beginning January 1, 2026, they expect that data will go from 2024 through 2025 when you're trying to figure out this compliance, basically. So when I see that, that makes me nervous, right? Because if we're using data from 2024, that means that, unless they change this, that TPAs, PBMs, other vendors right now need to be gathering that data right now as of January 1, 2024. If you haven't already been gathering what they're going to be expecting you to have on hand, we're already behind the 8 ball here. So again, put some pressure on the industry, even though the reg is not finalized, even though this is just in a technical release, it indicates that we may need to be compliant with it sort of right away. Other things that they mentioned in technical release that they're going to be looking for data on: the percentage of in-network providers actively submitting claims, time and distance standards, again, how closely do people live to various providers, reimbursement rates, are they sufficient, are mental health professionals kind of being paid less for the same service, and other aggregate data collection. What else do they say in the technical release? Agencies specifically say that plan sponsors of self-funded plans, they think, will work with their TPAs and other service providers to obtain this data. To do, probably once the regulations become final, I'd say most every employer is going to want to update their service contracts with their TPAs and PBMs and other vendors to ensure that they provide this data, that the data is accurate, that it complies with these rules, etc. Other items here, MHPAEA litigation that continues to be an active area. Probably the biggest initial one was just 2 years ago, 2.5 years ago. UHC agreed to pay $15 million to settle a DOL lawsuit. There's an important case called WIT versus United Behavioral Health that remains ongoing. Tons of lawsuits, hundreds of lawsuits about individuals and claims, especially related to long-term stays in substance use disorder facilities. That is definitely a hot area from a legal perspective. Other practical considerations, now that you've heard part 1, now that you've heard part 2, what are kind of the practical thoughts here? So first of all, nobody can do this alone. No plan sponsor is going to have all this data. You've hired TPAs, you've hired PBMs, they're the experts, they have the data, they have the experience, they have the operational know-how of how things work. So again, you as a plan sponsor are probably going to put pressure on them to help you out. They don't have to help you out. They may charge for it. They may say, no, you're on your own. But again, having that discussion, I think, is a good starting point. Trying to determine compliance in operation, again, means that you just can't look at the plan document or SPD. That's a minimum requirement. You should be looking at your plan document. You should be looking at your SPD to identify issues. But that's not going to be sufficient. So it's kind of minimum, but not sufficient. You need to go beyond the plan document, look at these underlying processes and data, assuming that the final regs continue to focus on data. Legal review may be necessary. Again, this is a sort of high-risk area, lots of lawsuits. The DOL, in the most recent data that I saw of how much they enforce, about half of all their enforcement activities involve mental health parity. So if you think about everything that the DOL enforces, ERISA, COBRA, HIPAA, etc., HIPAA portability, not HIPAA privacy, half of everything is devoted to mental health. So they continue to really, really view this as an important point. They really, really, really want to make sure that the industry is compliant here. So again, I do foresee many employers wanting some kind of legal sign-off here. In addition, someone is going to need to crunch the numbers, whether that's a TPA or PPM. Hopefully it is. If it isn't, again, it's going to be your burden. The penalties can include lawsuits, court orders, and possibly ERISA monetary relief and IRS penalties of $100 per day per individual. So there are some, significant risks and penalties here. What steps should you be taking now? Update your 2021 analysis if you haven't, looked at it in a while. Finalize it, or if you haven't started it, start it. It's good to start that 2021 analysis. Probably wait here until 2024 to see what the final regulations say for that piece. I haven't had any clients actually, start doing an analysis, but it's more of the let's discuss it with the vendors. Let's kind of think through this. Let's make sure the vendors are gathering the data, things like that. So eventually, I think you're going to have to update your contracts, but I think most folks are waiting until we see what the final regulations say. Other summaries, again, kind of think through these different gaps or other issues that you may see, and again, talk to everybody. My contact information is here. If you need assistance, we're lawyers. We're happy to help. In addition, if you happen to use other vendors, if multiple clients come to us and use the same vendor, we just kind of split the cost of it, and that seems to work pretty well where possible. All right, and so with that, I think we might turn it over for questions.
Yes, thank you so much, John. This is such an important topic, and as you said, people need to begin gathering the information now, so very timely. We have quite a few questions that came in before today's session, but if you have questions, please put them in the chat now, and we're happy to answer them. The first one I have listed here is from Sarah at Flambeau. How does this impact requiring our health plan to cover gender transitions and gender dysmorphia?
Yeah, that's a great question. So in terms of covering affirmative benefits, MHPAEA doesn't really do that. They talk about how if you just say you don't want to cover a particular benefit, you have some flexibility to just kind of completely exclude it. Like, for example, I have one client that doesn't cover any mental health benefits at all. So that's unusual, but MHPAEA does not require them to cover mental health benefits. It's more that if you do cover a benefit, then you can't impose an NQTL more stringently against the mental health benefits. So I haven't seen a lot of case law affirmatively saying you must cover, gender dysphoria here with regard to MHPAEA. Now that particular one, there is other guidance out there. If you're subject to ACA Section 1557, you may have to cover it. There's also some guidance, some litigation out there saying that everybody who's subject to Title VII of the Civil Rights Act of 1964, which is many, many, many employers, that you may have to cover it. But that's a disputed position. There's ongoing litigation on that. So in terms of covering gender dysphoria treatment, 1557 may mandate it. Civil Rights Act may mandate it. Haven't really seen much in the way of MHPAEA litigation suggesting that you have to mandate that coverage there.
Okay, thank you. Lori from Rhodes International is wondering if there's a tool that companies can use annually to update their audit.
Yeah, I wish that there was. The DOL, you can hop online, you can Google it. I mean, the DOL has what they call a self-compliance tool. So that sounds really promising, right? If you can find it very quickly, but the problem is the self-compliance tool hasn't been updated in a number of years, and the letters that we've seen from the DOL ask a ton of questions which go well beyond anything hinted at in the tool. So in other words, if the DOL as part of this process maybe recommits itself to update that tool on an annual basis, that would be a really nice source. But so far, historically, they have not done that. And so that tool, I think, is becoming less and less useful as time goes on. They kind of move beyond it.
Great. Eric from the Society of St. Vincent de Paul asked, how do we communicate with employees struggling with mental health and addictions while respecting sensitivity and privacy? If you don't mind, John, I'll take a stab at this one. I think that kind of comes back to a lot of what we talk about, and even the handout that we've included is really making this part of your culture. I think it's important to make sure that people know that there's a resource where you are and that it's okay to talk about your struggles. By trying to create that open workplace, that culture of care, I think that is kind of the most important thing. Those people will likely need to reach out to you. I don't think you can make assumptions about whether someone is struggling or not, but making sure that they know that there's an open door is really helpful. One other thing I wanted to mention, because I know John mentioned it on this in this discussion, is that As of right now, because we're the network for a lot of you, our employers, our network is compliant with this act. So we'll continue to get guidance from John and others, but at this point in time, we are compliant with the act. I have one more question I'm going to try and sneak in here, which is Carrie from Ayers Associates wants to know, what resources or data can we use to justify our plan decisions?
Yeah, that's a great question. And so, in the slides, we mentioned some of the examples of what the DOL is going to be looking for, like, for example, the time and distance data. Many TPAs have that right now, where they kind of draw circles around where your employees live and try and figure out, do we have enough providers within this radius so that that there's enough coverage. Some TPAs actually track like waiting time periods. If you call up today and want to see a medical professional or a mental health professional, how quickly can they get you in under our network? So some of the data exists right now. It may just be a matter of, again, kind of talking to your TPA, trying to get that data pulled.
Great. I got a couple more questions about rural areas, but I think you started to address that in regards to kind of the geography there. And so we only have a couple more minutes left. I'm gonna see. There is a question here from Michelle, just asking about how this pertains to mental health and billing. I guess when I see that, because it looks like it's coming from one of our providers, that makes me think billing happens through a TPA and claims are sent to the Alliance. For the most part, those plans are different since they're self-funded plans. So I don't know that I can answer it exactly, but Michelle, if you want to touch base with me offline, please let me know and I'm happy to help. And with that, I think I'll wrap up today's event. I just want to thank you again, John, for being here today and sharing your knowledge with us. We really appreciate it and hope this is helpful to our employers.
Thanks.
So with just our last couple of minutes, I just want to let you know we're here to help. That's why we put on events like today. If you're a member of the Alliance and need additional resources, or if you're considering self-funding and would like more information, please feel free to reach out to me and I'll connect you with the appropriate person at the Alliance. And don't forget, we've created some handouts today. They should be available in that sidebar menu to download them, but we'll also send those out with the link to the video from today's event. If you need anything though, feel free to reach out to us at events@the-alliance.org and we'd be happy to help you. You'll receive an email following today's event with a short survey and directions how to apply for CE credits, but please fill out that survey. We really appreciate your feedback as we work to improve our sessions and provide as valuable content as we can. And finally, please save the date for our February webinar talking about benefits, keeping them in focus year-round, and our spring symposium, which will be our only in-person event this year in April. Thank you so much for your time today. And when you think about the Alliance, please think self-funding smart. We'll see you next time.